so I have no conflict of interests or financial disclosures. So at the end of this session, what I hope is that we'll have a short piece around defining where we are with endometrial cancer at the moment, but then move on to think about where the new molecular and histopathologic data fits with the next generation of clinical trials. And interwoven throughout that, think about the challenges that we face in improving outcome for women with this disease. So why do we need to do better? After all, it's the good cancer, it's got great survivals. And I think historically that has been reflected in limited funding for endometrial cancer research. And Jessica McAlpine and I have just written a piece for Cancer, an opinion piece. And these figures about the differential in funding that endometrial cancer researchers received from that article. And I think it's quite striking that resources have been limited in this area. And perhaps with the patient demographic, there has been a more limited advocacy movement in endometrial cancer. But why should we care about this? Well, endometrial cancer has seen a striking incidence in the death rate over the last 20 years or so. And when we think about that in the context of what the incidence of endometrial cancer is going to look like moving forward, we're really on a cusp of an explosion in the number of women affected by this disease. Now, there may be multiple factors for that: rising rates of obesity, delayed childbearing, reduced rates of hysterectomy, and of course the aging population. But even I was at a meeting in Kyoto in Japan and was speaking in the same session as one of the physicians from Korea. And these data look very similar whether you're here or whether you're in Asia. So it's a worldwide issue in terms of thinking about endometrial cancer moving forward. Where are we at now? Well, I think, as we'll see in the next few slides, that systemic treatment really has quite limited efficacy in this disease. We don't really, as we've heard in the previous talk, have all the answers to who we should be giving adjuvant treatment to in terms of systemic therapy. We have the patient demographic that should be central to all our consideration of treatment and to clinical trials, and a high frequency of comorbidities and issues around illnesses such as diabetes in this population and polypharmacy. We have no approved molecularly target agents. We have no validated predictive biomarkers. And from the excellent talk this morning, we're aware that there are some challenges posed by histopathologic classification. And I was very grateful for my next slide to get approval from Martin before I put this up there. You know, historically we've thought about it in terms of the type 1, type 2 cancers, but I think really now we're challenging that paradigm and thinking about whether this is outdated and whether we should abandon what's been a very deeply rooted school of thought in terms of how we manage these cancers, and I have approval to say that. So turning to the systemic treatment of metastatic or recurrent disease first. I think I'm correct in saying that the last large-scale randomized clinical trial to be fully published was GOG 177. And in that trial, the previous standard of adriamycin cisplatin was proved to be inferior in terms of efficacy to the combination of paclitaxel, adriamycin, and cisplatin, or TAP. But this was perhaps an example where we have to think about our patient population, because that regimen is difficult to deliver, it's toxic, and for most women, the quality of life that is associated with this simply poses challenges that render it not easily deliverable in this population. So the community really voted with its feet, especially with the advent of carboplatin and paclitaxel, and adopted this on the basis of retrospective data, small series trials. Now we've seen from GOG 209, and this has been only the second interim analysis has been presented. It isn't fully published at this time, and I checked with Ginny Fleming at the weekend just to make sure I don't make a fool of myself in here. But essentially in the analysis that was presented at the IGCS, what we saw was compared to TAP, the carboplatin paclitaxel appears to be equivalent in this planned analysis to that regimen, and also better tolerated in terms of its toxicity profile. Clearly, we're waiting for the full publication of that data. But what I would draw your attention to is that median PFS and OS, we can do better. I believe that we can do better for the women that we are treating, and we need to advance the science. When we think about second-line treatment for this disease, most of the response rates are under 15%. And for those of us who use carboplatin paclitaxel and think about a second-line treatment, although it's not on here, again, there's limited data on the efficacy of doxorubicin, for example. And again, those response rates and data are limited in terms of outcome. And if we look at all of that together, the progression-free survival for second-line treatment is only around 4 months. So I would challenge you with, is there really a standard of care for second-line treatment? And a lot of this data in the first couple of slides were borrowed, and I used that, I did ask her permission, from Elise Cohen, and from a uterine trials planning meeting that took place in January in Washington from the Gynae Cancer Steering Group. And actually at that time there was a representative from the FDA there who questioned whether in go-forward trials in the second-line setting we actually need to have a chemotherapy standard of arm to compare with because the outcomes were so poor. And I know going through the steering committee and trials, it's been difficult to define what should be considered as the standard of care in this population. And I guess one other topic to touch on is the role of platinum sensitivity in endometrial cancer. There are studies out there, and I think anecdotally we all know that if our patient relapses 2 years out, then we think about retreating with carboplatin Taxol or a platinum-based treatment. So again, I think we could do better, and there's more that we need to think about. When we come to the hormonal treatment of recurrent and metastatic disease, this slide has actually been in various of my slide decks since I started at Princess Margaret, which is, how long ago, Sarah? 2000 and something. 10 years, we try and forget about that. And essentially, I think, you know, we kind of use that type 1, type 2. We take multiple factors into consideration when we think about using hormones in our patients. But there isn't really good, high-quality data on which ones we should be using first and in which sequence we should be thinking about that. It's more the art rather than the science of medicine that comes in here. When we look at the different classes of endocrine therapy that we've seen, and there's been a range of trials, single agents and also alternating regimens trying to exploit the biology of this disease, again, we see these median overall survivals are modest and of interest, and we use these drugs, but again, areas where we can do better. And one of the fundamental questions that I don't think we've really adequately answered is who really responds to hormonal therapy. It's not like breast cancer. You know, we have papers where people who are ER/PR negative respond to hormonal treatment. And one of the conversations I was having with Martin just before I started this talk, he has some interesting ideas. You know, breast cancer is very regimented about how we do ER/PR status, on what tissue. Obviously, we have a very good assay. But often for endometrial cancer, you know, perhaps we should be looking at that biopsy up front, not at the hysterectomy specimen, and it's been mixed through there. So I think we've got work to think about how we standardize doing this so that we can interpret our studies moving forward in a more optimal manner. We don't know the optimal sequencing regimen, and the Cochrane review in 2010 questioned the efficacy of this, although actually pointed out that there was limited randomized evidence to base this on. I'm just going to say a word on adjuvant systemic treatment, which was so eloquently covered by our previous speaker. obviously we had the Randall paper that looked at the adriamycin cisplatin whole abdominal radiotherapy comparison. But we've had limited randomized trial data, and I just focused on the NSGO EORTC Hogberg paper that was reported with the MANGO study. And we had pelvic radiotherapy versus radiotherapy plus 4 cycles of chemotherapy. And it was multiple different regimens, so we haven't really defined what we think is the best regimen to use here. And obviously the phase 2 studies that were presented by our last speaker and sandwich regimens. And again, we have the Cochrane review saying we need more data. These studies that were highlighted earlier, PORTEC-3 and GOG-258, which have completed accrual, we're hoping to have those data come through in the not too distant future. PORTEC-3, from the point of view of quality of life and toxicity, was presented at ASCO last year, and obviously the chemotherapy-containing arm had more toxicity in it, but it looked like the quality of life was improving the further you got out, so it looked acceptable, but clearly we need the primary outcome to make decisions on our treatment. So we have questions here, as our previous speaker highlighted, in terms of optimal regimen, adjuvant hormonal treatment. There's data out there on using it, but not in a randomized fashion to make our decisions. And clearly, the timing of how we deliver this treatment. And back to our first speaker around molecular classification, the TCGA data identifying these different subgroups, and then those sort of pseudo more clinically applicable markers that we're seeing emerge out of the Vancouver group, and also out of the TransPortec group, which is the translational piece of PORTEC-3. Are there any of these patients that we can save from having adjuvant treatment based on histopathologic molecular classifications? We know that we have these markers, but what does that mean for adjuvant treatment? TransPortec, the pilot study looking at the assays that will be used has been done, but we are going to be looking in PORTEC-3 at those groups as worked through with the Leiden group to see if by molecular classification we can identify people who may be able to avoid the toxicity of adjuvant treatment. I think this is essential, and it's something I feel very passionately about, that we need to build good collaborative relationships, utilize the tissue collections we have, and I know that Marcus and Steve, as part of the CCTG Endometrial group, and also build those types of relationships that allow us to answer those questions. But we really need to be asking these moving through trials, and I look forward to seeing what the TransPortec data is going to look like. So what's new in systemic therapy? Again, back to that TCGA, and I'm kind of using it as a shorthand for a lot of the other papers that followed on from this. But should we be looking at clinical trials focused on these individual groups? Or should we be stratifying our go-forward clinical trials that we're investigating on the basis in terms of the interpretation we make out of that data? In addition to the different subgroups, we've also seen a plethora of papers identifying potential molecularly targeted actionable mutations and what we'd call actionable opportunities in this patient population. And if we look at that, perhaps top of the list has been targeting the PI3 kinase pathway, but also looking at FGFR2 and other aspects of this process. So there's a lot of thought there. We just need to move the science forward. And again, that trials planning committee meeting that was held was part of it, was to try and move this process and think about what we should be doing next. So where are we in terms of targeted therapies? And this is just a little bit of a snapshot of some of the more mature data that's out there. Well, we've seen a number of single-agent trials looking at angiogenesis inhibitors. And for the majority, the response rates, again, around that 15% mark, and progression-free survival at 6 months, again, around those similar points. So modest activity, and as yet, we haven't identified predictive biomarkers. Again, targeting the PI3 kinase pathway, very attractive, and not only just because of PIK3CA mutations, but also because of the loss of PTEN, which occurs in around 50% of these cancers. And perhaps most furthest along in terms of where we've seen this is the Rapalog category of mTOR inhibitor. This pathway can be a little challenging in the endometrial cancer population because of the toxicity profile of some of the PI3 kinase inhibitors. The other thing that makes this attractive is the interplay of this between the receptors going through this pathway, ER receptors, and also the insulin growth factor pathways that interplay in here. So I'm just going to highlight the CCTG studies that have been done with Rapalogs. IND 160A and B that looked at temsirolimus, I always can't say that one, and IND 192 looked at ridaforolimus, that was better. And again, what we were seeing in these trials in patients that had had both chemo and no chemo, that response rates were modest, progression-free survival was modest, but there were some real outliers, that people that seemed to be doing a lot better with this treatment. To date, we have not been able to successfully identify a predictive biomarker for these agents, and we did quite extensive analysis on this collective trial sample population, looking at PIK3CA mutation, PTEN loss, and a variety of other factors, and we didn't find anything there. Is that because there's nothing to find in terms of predictive value in the PI3 kinase pathway? Probably not. I suspect it more reflects the Rapalogs, and I have a suspicion they're more of angiogenesis inhibitors than true. There's a lot of outs for Rapalogs as an inhibitor of this pathway. So modest response rates, some long-term, but we still have to dissect this a bit further in combination and alone and work with this pathway to understand it better. So what news on the combination studies? Last year at ASCO, Carol Akajanian presented the results from 86P, and this was a trial that saw patients in 3 arms of a study compared to a historical control, which is actually the carboplatin paclitaxel arm of GOG 209. So one arm, patients received carboplatin paclitaxel and bevacizumab, followed by bevacizumab maintenance. In the next arm, they received the Rapalog temsirolimus with temsirolimus maintenance, and then ixabepilone, carboplatin, and bevacizumab. Ixabepilone based on a GOG or NRG study that had shown some promising activity for this disease. One of the things to note about the patient characteristics in this trial is that there was an imbalance in good prognosis disease favoring the carboplatin bevacizumab arm compared to the other 2 arms. So the primary endpoint of this trial was progression-free survival, and what they found was that there was no difference in the arms compared to the historical control. When they looked at the overall survival, there was a benefit for that carboplatin paclitaxel bevacizumab group. The challenge here is that slight imbalance in the arm and understanding what that truly means in that context. One thing I would highlight that is very important from this study is it's got a very big correlative program that runs with it, and that will include looking at those different stratified groups, and I believe Doug Levine is leading this. So where did we sit with bevacizumab in endometrial cancer? Well, that study didn't reach its primary endpoint, but overall survival was better. But there's some question about the imbalances and also about compared to the historical control. There was a further trial presented at ASCO, the MITO-N2 study, which suggested there may be evidence for improved outcome with bevacizumab, but at the moment there's not really sufficient data to recommend that as a standard of care or to go to PCODA or Health Canada with that. So I think that that's more of a watch this space for where this goes in the future. And I'm told by our collaborators and colleagues the other side of the border that bevacizumab may be used for patients who have no options, but it's not actively being used in combination currently in the US either. So We have everolimus, letrozole that we're also seeing that's come through in terms of combination, but again, modest, good response rates, modest benefit. And in thinking about what else, immunotherapy, very hot topic at the moment, and I think there's a session at CCTG that will be looking at all aspects of immunotherapy, so I'm not going to make a fool out of myself and go through this, but clearly we're looking at checkpoint inhibitors that can take the brakes off the immune system. We know for certainly for melanoma that mutational load makes a difference in terms of chances of response to these agents, and we also know that a bigger mutagen-antigen repertoire results in a better chance. And if you can see, ovaries down there in the middle, melanoma's up at the top, but uterus and cervix are somewhere in the middle there, so promising target. The reason this has become a hot topic is pembrolizumab, which is phase 2 study that was done in DNA mismatch repair deficient tumors. 3 groups, mismatch repair deficient colorectal, proficient colorectal, and then other, of which 2 were endometrial cancer. What we saw was a distinct response in the mismatch repair deficient cancers, and there were also responses seen there. I don't know if any of these were the endometrial cancer patients. But clearly MSI patients were doing better, and when we think about it in the context of endometrial cancer, those poly and MSI high cancers have higher immune infiltrates, higher CD8 TILs, and signatures that are promising. So good target, good topic to think about developing an endometrial cancer, but I'd highlight that the poly MSI are also the good prognostic cancers. But just a word of caution, and one thing that I think we have to be cognizant of, because we're catching up in endometrial cancer, is to watch out for other tumor types because and learn from them. So in melanoma, P10 loss has been shown to be a possible predictor of resistance, and of course P10 loss is common in endometrial cancer. And we know that these responses with immune therapy are short-lived, so we have to think about whether combination studies are the way to go, different things. So I think what we have to do is think outside the box in terms of what we're doing as we develop these endometrial cancer studies and learn from other tumor sites, also learn from our patients in terms of what will be tolerable based on the profiles in the other diseases. Very quickly, I'm just going to say about DNA repair. Again, another potential target. We have potential targets there, both in the serous population and in others. ARID1A looks promising with PARP inhibitors, and there's an awful lot more out there that I haven't even touched on in relation to hormones and FGFR inhibitors and other areas. So in summary, I think we've got a rising need based on incidence and the number of women that are dying from this cancer now. I still think we've got a lot of work to do on the basics and how we interpret it, and we have to be very cognizant of our patients when we think about how we develop therapies. I think, as Martin so clearly demonstrated this morning, one size is not going to fit all, and we have to move that forward and be smart when we design trials and think about therapies. And we have to look at validating and optimizing what we do, and we can't do that without collaboration and involvement of everyone. So I'd just like to acknowledge all the peoples that I have borrowed slides from and who have thought about this, and add Martin onto that list because I grabbed him to have a conversation before this talk. And thank you very much.